Now we're going to the second expert, Ms. Silvia Galvino-Günther from France. Please, Ms. Galvino.
Thank you for your presentation. I'm Silvia Calvino from the Medical Intensive Care Unit of Grenoble in France. And I'm going to talk to try to explain you what you are going to find when you arrive in a critical unit from a very bedside perspective. So when you arrive to the intensive care unit, you will find that patients are remarkably connected to many different lines and tubes, like the patient on the picture. These lines and tubes can also be divided in two basic groups. The physiologic monitoring connections, non-invasive, which will be displaying on a screen with different vital parameters: oxygen saturation, heart rate, electrocardiogram, blood pressure, or the lines for administration of drugs and fluids, and blood sampling for laboratory analysis, which are mainly invasive as they need an insertion on a vessel. The physiological parameters, mostly on waveforms, currently displayed on IC monitors include the oxygen saturation of the blood acquired from a pulse oximeter, the heart rate, and eventually a respiratory rate, although this one will be always be monitored from the ventilator if the patient is connected to a ventilator, and they are acquired from external transducers and the electrocardiogram waveform, and the blood pressure acquired through an external pressure cuff or in many times from an arterial catheter. Their aim is to guide medical management so as to prevent or treat organ failure. In the right picture, we will find in green the heart rate wave from the ECG waveform, the oxygen saturation in blue from a pulse oximeter, and the blood pressure, this time taken from an arterial catheter. More invasive but very currently found devices in intensive care medicine are arterial catheters and central venous catheters. Now first, the arterial catheter participates to both categories, as it's an invasive device, but it will allow physiologic monitoring by the continuous measure of the blood pressure, and one of the essential parameters in critically ill monitoring, and arterial blood sampling as it's inserted in an artery. The central venous catheters are also invasive devices. Their main interest is to allow the administration of different kinds of drugs safely and rapidly. They can also participate in a lesser way in the monitoring of physiological parameters, as they can measure central venous pressure. But this measure has to be taken in specific contexts, cannot be considered singularly. We are going to detail all the elements we have already talked about. First of all, the electrocardiogram. An electrocardiogram is a diagnostic, non-invasive tool routinely used in ICU patients. It will allow to assess the electrical and muscular functions of the heart. And you are going to see the display on a screen like on our right, on the right screen. The cardiac monitor will be connected to a cable lead and skin electrodes to place onto the chest. They will capture the electrical activity predominantly through a single view. Most commonly, it will be lead 2. Actually, you will see that most of the manufacturers will provide you with diagrams to place properly the different electrodes. They can be either 3-lead or 5-lead monitors. Most of the manufacturers will also have a detailed explanation for how and where proceed the placement of the electrodes. Many times they would like to use the electrodes on bone, but it's not so obvious to place it in most of our patients. The reading of the continuous ECG will provide the following information. The most common information will be the heart rate and the heart rhythm. Normally, and it's common use to say that the normal heart rate is between 60 and 100 beats per minute. Under these numbers, it will be bradycardia, and over these numbers, it will be called tachycardia. The normal heart rate is a sinus rhythm, regular with a round P wave before every QRS complex, all the same shape with normal P wave axis, and regular normal PR intervals, QRS complex, normally positive in D2, and QT intervals. The heart rate monitoring will be able also to record any supraventricular or ventricular extrasystoles, and even if there is a pacemaker training. We'll also be able to show the conduction, normal conduction, or the presence of blocks, atrioventricular block or bundle branch block. Of course, if you have a circulatory arrest, there will be a red alarm, and it may be in the cases of asystole, ventricular fibrillation, electromechanical dissociation. Problem is, the continuous ECG we have in the ICU can have some major limitations, especially when it's in terms of the repolarization monitoring. And when it looks for ST segment abnormalities, there's variations in repolarization that there are the evidence of damage to the coronary arteries. Ischemia detection is incomplete when monitoring only one region, and it will not give information about the electromechanical cupping of the heart. So myocardial and ischemia interfaction will be less easily detectable. Some electrolyte disturbances, anyway, will be more visible on the continuous electrocardiogram. If ever there's a doubt about the ECG interpretation, anyway, the doctor will ask for a 12-lead ECG, and this will be performed and analyzed. In these cases, you will be able to see very accurately and analyze the QRS, if it's a normal width, if it's a prolonged width, if the QRS are regular or irregular, the presence of P waves, and if they are followed by a QRS, and if the ST segment is elevated or depressed. And you will see it on a sheet of paper, which will be much easier to analyze. A special case you can find if ever you have COVID patients is how to place the electrode when your patient is in prone position. Actually doesn't change so much. You will monitor the electrocardiogram in the same way, and the signal will be equally informative. You have only to check that you place correctly the electrodes. You have just to invert the red and black and green ones, and you will obtain the best signal possible. A second device that you will certainly use, especially in COVID patients or patients with arterial, acute respiratory distress syndrome, is the peripheral pulse oximetry. Oxygen saturation in the arterial blood provides information on the adequacy of respiratory function. The saturation of oxygen can be assessed non-invasively by pulse oximetry, and in this case, we are going to call it SpO2. It will be a small glove-like or clamp-like device that will be attached either to a finger or on an earlobe. It's most commonly anyway put on a finger. The signal is based on the differential absorption of light by oxygenated and desoxygenated blood during pulsatil blood flow. Hypotension, peripheral vasoconstriction can alter readings. As well, smoke inhalation or carbon monoxide poisoning that can cause high levels of carboxyhemoglobin and also skew pulse oximetry readings. Normal pulse oximeter readings usually range from 95 to 100%. Values under 90% are considered low. But anyway, all these values have to be checked and adapted to the patient condition and the patient state at the moment of you take it. Pulse oximeter, as we saw before, can be questionable in some hemodynamic and stable conditions. You will have to check for the accuracy by observing the waveform. Does it follow the cardiac waveform? Is the amplitude appropriated? Does the pulse number recorded by the oximeter correspond to the one of the heart rate? If you see in our picture, the pulse recorded here by the oximeter is identical to the one recorded by the ECG, 95. and the amplitude of the wave is correct and follows the cardiac wave. So you can be certain that this saturation is reliable. Now we're going to see arterial catheter. This one is already an invasive device. It's a common procedure to the intensive care settings and the operating room. It involves the placement of a catheter into the lumen of an artery and provides at least continuous display of blood pressure with access to frequent arterial blood sampling. The radial and the femoral arteries are the preferred site of insertion. So on one side you will have a catheter placed, and on the other side you will have a monitor. And in the middle there will be a transducer that will read the fluctuations in pressure and change them into an electrical signal displayed as the arterial waveform in a monitor. So, although blood pressure will be always monitored in intensive care units, at least by a blood pressure cuff, some conditions will demand the insertion of an arterial catheter. For instance, a rapidly changing clinical circumstances in critically ill patients, hemorrhage, sepsis. When you need to monitor and guide the use of vasoactive drugs with rapid cardiovascular effects. If you have to monitor and guide acute interventions, can be the case of major surgeries or resuscitation, and if you need repeated blood samplings. This arterial catheter will give you more information and very reliable information. The measure of the systolic arterial pressure will be a reflex of the left ventricular afterload. The diastolic pressure will give you a good reflection of the arterial tone. And the mean arterial pressure is a determinant of organ perfusion pressure used as a major target for hemodynamic resuscitation. So, in order to have an accurate measure of the arterial pressure, some considerations while connecting the arterial catheter have to be taken into account. First of all is priming the lines, and the second one will be zeroing the arterial line. Priming the line, actually, it will have two main reasons. The one and most obvious is that if you have to connect a line to a catheter going to a vessel in the patient, this line cannot be empty. It must be primed with saline solution. The second one is that this line will be used to transmit a signal, and if there are bubbles, you will not have a right signal. Zeroing is designed to negate the influence of external pressures, such as the atmospheric pressure on the monitoring system. The zeroing the arterial line ensures that only the actual pressures from the patient will be measured by the transducer, thus providing accurate data on which to base treatment decisions. First of all, you have to spike the pressure bag, remove air and drip the chamber, squeeze the flush device, and evacuate air from tubing and stopcock. Pressurize your bag to 300 millimeters of mercury in order not to contaminate the transducers. By using a bubble-free technique, connect tubing to the arterial catheter, and then level the open-to-air stopcock port onto the phlebostatic axis. Press 0 in the monitor display and close stopcock to air. Turn stopcock into open to patient position and assess waveform. So at this time, we're going to ask what can be a phlebostatic axis. Well, actually, the phlebostatic axis is a point located by drawing an imaginary line from the fourth intercostal space at the sternum and finding its intersection with an imaginary line drawn from the center of the chest below the axilla. It's the specific reference point for the arterial transducer is actually the aortic roof, but both the aortic roof on this phlebostatic axis are very close to the right atrium, and they are also considered both the same reference levels. You have to take into account that for every 10 centimeters below the phlebostatic axis, the arc line will add 7.4 millimeters of mercury of pressure. In our unit, to avoid this complex situation, we actually put our 0 point of the transducer on the arm when the patient doesn't move. and so it will always remain at the level of the aortic roof or the phlebistostatic axis. The problem is when the patient will start to move, especially the arms, because in this way, when the patient doesn't move, if the bed moves or if we have to sit a little bit more the patient, it will always remain on the same place. So I have shown a first drawing about the monitor, the pressure bag, the transducer, and the catheter. Here you can see with the pictures what it could look like at the bedside of the patient. You will have the catheter here on the right, which go with the lines until the transducer. The transducer will be connected to the pressure bag and to the second transducer, and this one to the monitor. So for the three devices we have seen already, electrocardiogram, saturometer, and the blood pressure control through an arterial line, we have to have a little word about alarms. When you monitor hemodynamics, you have to think that you are monitoring the circulatory condition. This means that you have to be able to anticipate any important changes on hemodynamic status before it becomes deleterious for the patient. All vital parameters, heart frequency, oxygen saturation, blood pressure will have alarm settings that will draw your attention in case of modification of patient's condition. But these alarms have to be adapted patient to patient and condition by condition, sometimes several times in a day. If we have already talked about the normal heartbeat from 60 to 100, you have to think that in intensive care units, you will most of the time have abnormal, or many times you will have abnormal numbers. So you have to adapt your alarms to these numbers and to the condition of the patient. It's a fact that an alarm that sounds too much is an alarm that we will not pay attention to. And in any case, it's precisely the opposite of its aim. In any case, an alarm should never be neglected. Here on the screen, you have the arterial blood pressure with over 117, which is also considered a quite high pressure, but will be tolerated in the case of these patients up to 170, because the patient is known as being hypertensive. In a patient who is not known as a hypertensive, perhaps the high alarm setting would be 160 or 155, it's depending on the condition and the situation of the patient. So now we are going to see the last of our devices, the central venous catheter. A central venous catheter is a thin, flexible tube inserted into main vein, jugular, subclavian, or femoral. A central venous catheter may stay in place for weeks or months and helps avoid the need for repeated needle sticks. But not only this, the main aim is to provide a high-quality vascular access for the patient in order to administer many intravenous fluids, drugs, or blood transfusions. Patients, anyway, under vasoactive drugs and in circulatory failure will often be equipped with a central venous catheter. As we will see later with a clinical hemodynamic case, CVC will also be able to measure the central venous pressure and even the venous blood saturation and oxygen. So a central venous catheter can also participate in a lesser measure to patient monitoring, but will always be essential for administering medications. And its role in the monitoring of physiological parameters will depend on the situation. The catheter characteristics. You have to think that this tube is made of biocompatible polyurethane material. It will be stiff and non-kinking at room temperature, but once in the bloodstream, it has to soften, and especially at body temperature. Its tip is specially designed soft and conical to ensure automatic, safe, and easy insertion. It will be a radio-opaque catheter with length markings to ensure accurate placement. But in any case, and after insertion, jugular or subclavian catheters have to be checked by a chest control. And you have the possibility to have many lumen, from 1 to 7. And we are going to see later why do you have the need of many lumen in critically ill patients. So each lumen of the catheter will be connected to a specific series of injection ports that will allow the administration of medication. Drugs will be administered either by gravity, like perfusion bags, or through electrostrain pumps, allowing a precise dosage of the drug. The identification of the different lumen ports will allow to prevent complications, like pushing drugs with a perfusion bag, and to be more efficient when administering drugs. The advantage of multi-lumen catheters are that, first of all, they allow a secure administration of most delicate drugs, like norepinephrine, in a dedicated line, avoiding unintended boluses by other medicines. You will be able also to separate medications by categories, vasopressors, sedation, nutrition, and to administer separately drugs that may have physiochemical interactions. As you are going to see in intensive care units, you may use drugs that will be able to interact with other drugs and lessen or potentialize their effects. And some of them will have the risk to clot together, like when you use heparin or furosemide. So it's essential to separate the drugs in different lumen. In our unit, we use 4 lumen catheters. So we have a line for vasopressors, a line for sedation, a line for hydration or nutrition, and antibiotics or other medications. What is the importance of identifying drugs? Well, actually, it's essential for security for the patient. The right labeling of medication will also be essential for the management of central venous catheters and will give us the opportunity to provide the 5 R. These 5 R's in medication are the right drug, the right patient, at the right dose, the right route, and the right time. They must be distinctly readable labeled, and in emergency situation, it will allow to administer easily any emergency drug through the right site and prevent any other complication. Another rule in drug administration is that the nurse preparing the drug has to administer it, and therefore each nurse has to put his or her initials on each bag or syringe they prepare and they administer to the patient. On the left, you can see all the labels that we use in our units. They are already pre-established, and they help us because they are used in all the intensive care units of our hospital. In the medical, in the surgical, in the neurosurgical, and the heart intensive care unit. So any nurse that goes from one unit to another will be able to easily identify the different drugs and lines. Specific standardized unit protocols in line management can save time and propose a secure frame for all this stuff. We have the profile labels I have shown you in this example, and the dose of the drug and the name is already written according to the color code installed by scientific societies. For instance, in purple we have vasopressors and endotropes, in blue morphinic medication, in yellow hypnotics. Each kind of drug will have its specific lumen. The proximal lumen will be for vasopressors, the medial one for sedations, the distal route, as long as it's of a proper width, for nutrition or filling, with an emergency port easily recognizable. So, routine inspection of the central venous or arterial line, regardless of location, should be performed daily. A daily inspection should ensure that the line is properly in place, free from infection and in working order. Any manipulation or use of the catheter should take place only after standard hand hygiene and clean glove practices with impregnated gauzes, at least alcohol 70% or chlorhexidine. Dressing changes for central lines should occur every 5 to 7 days with a transparent dressing or every 2 days with a gauze dressing, in order to survey the insertion point. However, if the dressing has a break in the seal or becomes visibly soiled, it should be changed. Recommendations include changing the IV administration set at least every 96 hours. And this can be every 24 hours if you have lipid solutions or you are transfusing blood derivatives. So, most of the critically ill patients will benefit from the use of insertions of these connections. The systematic basic monitoring through electrocardiogram, pulse oximetry, and blood pressure, mostly with an arterial catheter, and the administration of drugs through a central venous catheter. If hemodynamic status improves with this therapy, it's reasonable to continue with the same monitoring until complete resolution of the hemodynamic instability or risk. However, if the answer is insufficient or an acute respiratory distress appears, their specific situation will require further investigation devices. Nevertheless, you don't have to forget that devices alone will not improve patients' outcome. Only the adapted therapy guided by these devices will improve patients' outcome. As take-home messages, I just wanted to remember 3 things. Connections, lines, and tubes are essential part in any intensive care patient monitoring and treatment administration. Although by themselves alone, as said before, they will not improve patients' outcomes. Their aim is only to allow the most adapted hemodynamic monitoring to guide medical management and administer treatment. Anyway, an adapted management of the devices will allow to anticipate or prevent complications and provide optimized, efficient, and safe care to patients. Therefore, it is of utmost importance to understand their possibilities and limits, identify and organize precisely the connections, and systematically check their placement, insertions, and patency. Thank you very much for your attention, and good luck.
Well, thank you very much, Sylvia, for this sharing this knowledge, and it's very clear, and it went really to the point. But I still have some questions, if you're okay with that.
Let's go.
Okay. So, what I was wondering, you explained, is it enough to have a blood pressure measured by the cuff, or do you really want this invasive catheter?
Well, actually, if the patient presents a hemodynamic instability, it's better to have a continuous blood pressure measure to survey and to anticipate any changing of the patient. It also will allow to monitor the administration of other drugs like norepinephrine, adrenaline, dobutamine. So it's much better to have an arterial pressure inserted on the patient. It also will allow to draw easier the blood samples.
Okay.
So many patients will appreciate not having too many stitches during the day.
So in fact, in the beginning, we can use the blood pressure cuff, but we will try to, as soon as possible, put a catheter in. Okay.
Yes, and it will last actually during the hemodynamic instability of the patient. When the patient has become stable again, you can withdraw or start withdrawing all these invasive or semi-invasive devices in order to prevent complications. But as long as the patient remains hemodynamically unstable, it's better to keep them.
I'm quite very pleased that you mentioned the prone position with the attention for the ECG electrodes, the positioning, but also about the level of the transducer. So this is really a main goal, to have the right figures on the right moment, to rely on them. So I'm very pleased that you mentioned it, because in COVID patients we have to turn them on the back and then back again to the stomach. And this can be very tricky with an arterial line to disconnect or to, but we have to take care.
Yes, prone positioning is always a challenge because there are so many lines around the patient that you have to be extremely careful when you have to turn your patient.
Mm-hmm.
We have installed the system of actually having the transducer on the arm just to prevent sudden changes of arterial pressure, which can be quite labile, quite can be modified very quickly when changing position. So we try to have it as accurately measured as possible without moving or without having to make too many changes on the too many zeroings or to survey too many times this kind of procedures.
And what is the most difficult curve to obtain with this critical patient?
Well, it seems very basic, but most of the times we have a lot of problems to have a proper saturation curve because the patients may have a vasoconstriction in the fingers. You can have hypotension, and this one will skew a little bit the curve. So you have to be extremely careful when monitoring because you don't have really to have to take into account only the number of the cipher you are going to see, but also the quality of the curve and to observe your patient. A number alone will not be reliable enough.
Okay, so if you have any doubt about one parameter, you double check it. If you have no good saturation, you will take a blood sample just to make sure you're in the right place with the right
range. That's right.
Yeah, okay, perfect. Okay, thank you very much. It's very clearly.